Assalamu alaikum, the short clinical station day. First scenario, you have to examine the cardiovascular system of Mr. John Smith. He is 45 years old, came for follow-up. Yes, you can start. Here you go.
Okay. Hello there. I'm Dr. Aisha, one of the medical doctors here today. Could you please confirm your name and age?
John Smith. I'm John Smith, 45 years old.
Hello, Mr. Jones. Is that all right if I can call you Mr. Jones?
Yes.
Mr. Jones, today I will be examining your chest. I will be inspecting, touching, feeling, and then listening at your chest. I will be looking at your upper limbs, examining your upper limbs and lower limbs, along with your face and neck. Is that all right with you?
That's okay, doctor.
During my examination, if you feel any pain or discomfort, please do let me know.
Okay, doctor.
All right. I'll take a step back and I will expose the patient correctly. From the knees, he will be exposed and appropriate. Could you please take out your shirt for me?
Okay. He has taken off his shirts.
All right. Thank you. So I will be looking for any erythema, any scars, or any edema in the legs.
Okay. There is. I've sent it to Dr. Bazin.
Okay, I will send it now. Wait, give me. Okay, I will start sharing the legs first. Okay, Dr. Aisha?
Yes.
As you asked for the legs, so this is his legs. Continue. I will add 1 minute for you.
Dr. Bazin, you've not done introduction. You've not started the case. Have you started the introduction?
Sorry?
Have you introduced the case, the whole case, the way your usual pattern of starting?
You mean Dr. Aisha, she will introduce herself?
No. Have you introduced the case, your usual pattern of greeting and starting before we start?
I couldn't understand what you want to do now.
Okay, no, go ahead. No, there's a way
Okay,
usually starts the presentation. Okay, it's okay.
Okay. I will pause the timer and I will add 1 minute for you. I will share both photos. Then you can do the examination.
Perfect. Okay. Is there more pictures, Dr. Basu?
Yeah. I shared the other one. You can start now. You have 4 minutes now. Okay, continue.
Okay, so all right. So I will be inspecting I will go towards the patient. Ask him to cough. Can you cough for me, please?
Yeah, he has coughed.
Okay. All right. I will see if the breathing is okay. Is it any dyspneic or cyanosis?
No.
Okay. I will like to check for your hands. Could you please put your hands in front of me, please?
Okay. Just check the hands.
How is the filling? The capillary refill time?
Normal.
Okay. I will check for any splinter hemorrhages.
No splinter hemorrhages.
Any Janeway lesion? Any ocular nodules?
No.
No. Okay. I will ask him to turn his hand and cock up his wrist. So, is there any signs of hypoxia, carbon dioxide retention?
No.
Okay. I will check for the radial pulse and radial. Okay, both the hands. Is there any delay?
No
delay. Okay, then I will just check the radial pulse.
Okay.
How is the filling? How is the filling? Volume, character, and
volume is normal.
Okay, and how is the character?
Character is normal.
Okay. Is it narrow? It is a slow rising. How is it?
Is it normal pulse?
Okay, everything. Okay. Now I'll be checking. I will be checking for the collapsing pulse. Mr. James, is that all right? Is there any pain in your arm? I will be lifting your hand. I will be lifting your arm. Is that all right?
Okay.
Okay. So is the pulse collapsing?
No.
Okay. At this point, Mr. James, I will be examining your radiofemoral pulse. Is it okay?
Okay.
And I will be doing the blood pressure.
Blood pressure is normal.
Okay. Mr. James, I will be looking at your neck. Could you please look at the extreme left, and I will be looking at the JVP.
Okay.
JVP is?
Normal.
Okay. I will be checking for the carotid for any bruise or anything, or how is the volume and the carotid pulse?
Carotid pulse is normal.
Okay. I will be checking for the apex beat now.
Okay. The apex beat is normal.
Okay. All right. I will be checking for the thrill. Any thrills?
Trills, yeah. Trills are normal, no trills.
No thrills? Okay. I will be checking for a heave.
Heave,
Is there
where?
heave?
Where are you checking for the heave?
Yeah, on the sternum. Putting my heel of my hand on the sternum and checking
On the
for the
sternum.
heave. Yeah, like mid sternum and checking for the tricuspid area or yeah.
Oh, okay. There's no heave.
No heave at the axilla. Okay. I will be now I will be auscultating. I will start with the left second intercostal space for A2.
Okay.
How is it?
There's no H is normal, no.
Normal. Okay. I will be checking for P2 on the right side.
Okay, normal.
Left sternal, left lower sternal. I will be checking for tricuspid.
1 minute left.
Yeah.
Normal. Not. What are you checking tricuspid? Sorry. What are you checking tricuspid?
The tricuspid valve. Is there any
What are you
murmur or
checking?
something?
Okay, murmur.
Murmur.
Okay, yeah. There's systolic murmurs.
Systolic murmur at the tricuspid area?
There's just a,
okay.
you know,
A systolic murmur. Okay.
A flow murmur and then a click.
Okay, a click is present.
Yeah.
Okay.
Yeah.
Okay, I will be checking at the apex for the mitral valve.
There's also a click too.
Okay, click is positive.
Click. Yeah.
Okay, and I will be asking the patient to turn at the left side, and I will be checking the mitral valve again.
Okay. Click.
Okay, click is there, yeah. Okay,
yeah.
Is the murmur radiating to the apex?
No murmur,
to the
just
axillary. Okay,
no.
only a flow murmur.
No.
Okay, I will check for the eyes and oral cavity. Is there any arcus, any corneal arcus or any xanthelasmas or any?
Yeah. There's xanthelasmas. Yeah, there is.
Okay, and in the oral cavity, anything like ulcers or blisters? No, nothing. Okay, I will check for the peripheral pulse. I will check for the limbs. Sorry. Is there any edema?
No.
You can see the picture, Dr. Aisha. Okay, time is up.
Yeah.
Okay, you can collect your thoughts. Then we will start the presentation right now. Okay.
Okay.
Yes, Dr. Hinari, start the exam question.
Okay. Can you present your positive findings in this patient?
This patient comes with a scar on the leg, which seems to be a graft, a scar from the venous graft or a harvesting graft is there. And when I look at the sternum, there is a midline scar, which is a scar of sternotomy. During my examination, I could hear a click in the apical region during my auscultation, and there is also a systolic murmur. There is no heave, there is no thrill, and yeah, just 1 minute. Just 1 minute.
Okay,
are you done?
Yeah, hello? Yeah, I'm
yes,
sorry.
here you go. Continue.
Yeah. So, and the murmur is heard at the axillary area. right? It is going towards the axilla, and it's a systolic murmur. The S1, you did not say anything about the S1 at the apex.
Are you done?
Yes. So
Okay.
according to my findings, my physical findings, it seems to be a patient who has a mitral valve replacement. Like it's a mitral valve replacement case. It's a case of, and
Okay.
it's
So how will you investigate the patient?
a metallic.
What are the differential diagnoses?
The reason that the patient got the replacement of the valve could be the underlying cause, and maybe the valve was symptomatic, and it was a regurgitant or a stenotic lesion. The main reason for the replacement of the valve could be rheumatic fever. There could be underlying causes like endocarditis or hypertension or ischemic heart disease as well. But one of the major reasons for the replacement of the valve um, could be the rheumatic heart fever.
Okay, so I will investigate the patient.
I would investigate. I would start with the bedside investigation. As I said, that I will be doing the blood pressure test and the complete examination for the chest. I forgot. For the chest, the lungs, and I will be doing the complete physical examination.
Okay, so
I will be doing the blood test for ESR, CBC, full blood count, ESR, CBC, CRP, checking for the 3 blood samples for any infective endocarditis or and ASL titers. I will be also doing the urine dipstick examination. The specific test would be the imaging test. That will be the echo to see is there any lesions or any vegetations in the valve. Yeah.
Okay, so how will you manage the patient?
I will be managing the patient according to the presentation. If there is the sign of any infection or if it is infective endocarditis, I would be, because Dr. Henry, you did not, there is no, like the case is not there. I just have to manage.
Sorry,
like
the case, I didn't get you.
Like, okay, I will manage the patient according to the symptoms. If there is a infective and if there is valvular problem, regurgitant or stenotic, and it is symptomatic, we will be treating it. We will be replacing the valve or ballooning the valve accordingly. If there is a infection and there is signs of vegetation, we will be treating the patient with antibiotics from looking for the culture sensitivity and treating him for 6 weeks of IV antibiotics or prolonged. Yeah, that will be the initial treatment, and then of course it will be accordingly what is required.
Thank you so much. Thank you. All right. That's a good one.
Yeah, I want to ask here, Dr. Henry. I want to ask here.
Yes.
Yeah. If you have patient with a replaced valve, what do you think this patient came for? What could be the complication? I mean, what could be the complication that's why the patient presented to you?
Maybe there is a regurgitation, or maybe the valve is failing. That could be one of the complications. Maybe he is having the heart failure, signs
in
of
the
heart
form
failure.
of
Dyspnea, dyspnea or palpitation or cyanosis or exertional like NYH a classification of heart failure.
Okay, you will talk about heart failure as a complication.
المفروض
Yeah.
ما تسوي نفس الوقت، المفروض دي تسوي واحد اللي بيسوي مرة واحدة في اليوم ده، والثاني تسوي صباح ومساء.
Okay, sorry. Let's continue. What
Okay.
other complication apart from heart failure, Dr. Aisha?
Endocarditis.
So the
Endocarditis
Perfect.
can be
Yeah.
one of them.
So infection. What
Yes.
else?
What else he can come for?
Exactly. Give me give me more examples of complication.
Maybe there is arrhythmias. He's noticing arrhythmias or
Perfect.
yeah.
Okay, what else? Heart failure, arrhythmias,
Yeah.
and
Yeah.
the infective
Infections.
endocarditis.
Yes.
What
Infections.
else? And it's not related to the valve itself.
Coagulopathy, like he easy
Perfect.
clotting.
So
Yeah.
medication, related to the
Yes,
medication.
In fact, that is what the patient has, but
The
you didn't check the back of
No.
this patient. You didn't
No,
check for
yeah,
bruise.
yeah. The lungs
Hey,
was also missed, and yeah, the edema was
Dr.
missed
Bazim,
because
let me finish before you come in, Dr. Bazim. You know,
yeah.
there's a lot of correct. Dr. Bazim.
Yeah, that's why I want to say
Okay,
what
okay,
complication
go
this
ahead,
patient
go
could
ahead.
be presented with.
Yeah, yeah.
We
Yeah.
spoke about some of them, okay?
Mm.
And the most important is infective endocarditis or
Yes.
non-functioning valve in the form
Yeah.
of, as you said, there is regurg.
Regurgitation or stenotic again. Yeah.
Perfect. So it could be failure. What else could happen on the valve?
On the valves,
Yeah.
these are the three things. I think that
So
it can.
regurgitation, thrombosis.
Yeah.
Do you think thrombosis might happen? Yes.
Yes,
Thrombosis.
thrombosis, regurgitation,
Perfect.
infections,
Perfect. Yeah.
or failure of
Or
the valve.
oh,
Yeah.
yeah, yeah. So how you know the regurg happen, or sorry, the non-function or the regurg happen?
Yeah.
How,
There
when
is a new
you
murmur.
say perfect, there is
Yeah.
new appeared murmur. Perfect.
Yeah.
And one more question I want to ask you regarding the commonest arrhythmia might happen on the mitral valve is
Atrial fibrillation. Yes.
perfect. Okay. Yeah, this is what I want you to say. So you have to speak about follow up for what you said according to the patient presentation, but give example of the presentation. What could be the presentation? Anyway, you did great. Let's Dr. Henry comment.
Dr. Basim, anytime
Yes.
when we're getting the short clinical case,
Okay.
I always feel that will they not give us any written thing like now when I'm examining this patient, on what basis I should start talking? Like there was nothing that I have to like. Why am I just looking at the pictures and what I should talk about? That's what I did not get even the last time.
It's simulation of the exam scenario, but without seeing the patient. We are just imagining and memorizing the steps of examination, how to do, what to do,
Yes.
and the presentation and the exam time. Okay, it's similar to the real one, but without patient. We are trying to simulate. Oh, yeah, what you want to say?
So I'm saying that Dr. Basim, when I
Okay.
come inside the room, like when I will
Okay.
go
Yeah.
inside the room, there will be only one thing written that I have to examine, or I will
Exactly.
be given something to read, like
Instruction. No. There is an
yes.
instruction as you see in the chat box. It will be on the wall.
So there is
Examine.
nothing in the chat box, sir.
No, I read it. Maybe you joined late. So examine Mr. John Smith, 45 years, presented to the cardiovascular for follow-up. Okay, you didn't see it? Sorry.
Okay. No, I did not. Okay.
Okay, I will
Okay.
share it again anyway.
Okay.
You have to find instruction inside. And
Okay.
if you don't find, let me know, because sometimes the message come before you joined, so you didn't see it. Anyway, this is the instruction.
Okay. He came for the follow-up, huh?
Yeah,
Okay.
exactly.
Okay.
Either they will
Okay.
tell you patient present with dyspnea, present with cough, presented with short of breath, or follow up. You don't know.
Mm-hmm.
Okay. So it depends on the discussion topic. They want to make the discussion on the complication or on the uh, presentation or in the finding. Okay.
Mm-hmm.
Don't worry about that. You will see the instruction very clearly. Okay. Dr.
Okay.
Henry will comment, and I will comment.
Yes.
Thank you very much, Dr. Aisha. That was
Mhm.
it's a good one. You know, you did very well. looking at, you tried in a way, but because you did not really get the scenario very well. You didn't see that was really because your step was not that bad. Just that let me start by making some correction.
Yes,
when
please.
you walk in, you look back, you do a general inspection like you did. You look at the legs, you saw the venous, the grafts, the vessel scar there. You look at the hands, you check, not just you scan through and check if there's any evidence of warfarin toxicity, like this patient has at the back. There's some bruises at the back, that you didn't ask for it, so you didn't see it.
Yeah.
He has been on warfarin, and he came for follow-up. There are some blood accumulation, some blood bruises at the back, which probably, but you didn't check the back. You'd have see some what they call it, some bruises there, some eschimosis there. Then look at the wrist. Sometimes, like in this patient, many times they may be having a wristband in the hand, showing that they are on warfarin. Sometimes, bracelet, like a bracelet.
Or a yellow
Look at the bracelet, basically. Then I love the way you checked at the Oslas node, it's beautiful. You check general lesion, you check those are good. You also check for the blood pressure, you did JVP. Now, while you are doing the precordium, you saw a mid-sternotomy scar.
Yeah.
When you are reporting, you also see there are three tiny, there are some drainage scar in between and beneath the scar. Did you see them?
No, I couldn't see. Okay.
Tiny ones.
Now I'm seeing, because I did not enlarge.
Now, look at the picture very well, because for your exam, there are 3 dots down. 3 dots. Typically, if it's a single scar, the highest you can see is a 2 drainage scar.
Yeah.
When you start seeing more than 2 drainage scar, most likely is a double sternotomy scar that the patient had.
Yeah.
You understand? So it's most likely the first incision, that was the first 2 scars you see there beneath as a drainage scar. Then the second incision they did, that was one at the third scar you see. So it has 3. There are 3 drainage scar with an incision in a mid-sternotomy scar.
Sternotomy.
So most likely the patient had. When you look at the click, you didn't time the click. You did not time the click.
The time was just running.
You should have, put your hands on the carotid and time the click. Is it at the first second house sound, or is it at the second? I just say click.
I did not say, but we do it.
No, I mentioned click. You should have said, okay. Is it an MVR, or is it an MVR, or is it both? Like this patient, it can be both.
Both, yes.
Probably you time it. Okay, you had the sound, the click at the first and at the second house sound. Most likely, you are dealing with what? A missed valvular replacement. A bivalvular replacement.
Bivalvular replacement, yes.
So there are some things. These are the things that will really affect your mark in the physical finding, the what do you call it, sign, identifying physical sign. Now the patient has xanthelasma, but you didn't say it when you are presenting it. You did not mention it.
Yeah, we did.
You saw it. You saw it. I said yes, but you did not mention it when you are giving your presentation. Even when you see it, you did not mention it. They will not give you that mark. So whatever you like, in my own case, in my exam, then there are some things I saw, but I didn't present it out. So I was minus. I was giving a negative mark in those because I didn't say it out. I saw those scars, but when I was giving the talk and mentioning the physical findings, I did not mention them. So so try to mention any sign you see. Like this patient, the xanthelasma that you saw, you should have mentioned it.
Okay.
Because that will give you what would be the reason why this patient have a graft scar and then a median sternotomy scar. Most likely is a CABG. Most likely he has a CABG. You did not mention it when you are giving your diagnosis, or you didn't mention CABG. That is what this patient has had. He had a CABG. You also had superimpose, probably had a rheumatic heart disease. That was the first surgery. And later he had probably a thrombosis from the warfarin, maybe the side effect of the clots, because probably was not taking warfarin, now developed an infarction. from the clot. And then that warrants you to do a CABG. That's a possibility. That is one possibility. That's why you are seeing a double stenotomy scar and then a CABG. That can explain it. It could be that probably the patient had a separate myocardial infarction and then later develop a rheumatic heart disease or probably a congenital heart disease or probably an infective endocarditis. It's not in all cases of infective endocarditis that you see the general lesion and the ulceral stenosis. It's just a very small percentage of patients that have. So absence of those things does not negate infective endocarditis. So these are the differential diagnoses you first of all, the CABG, which you see clearly, and then the rheumatic heart disease. You can have the surgery, in different time. So the patient is coming for follow-up. Most likely he has a problem with ecchymosis.
Yeah, I did not get the case.
Or pupilla. So your investigation you will do in this patient, first of all, lipid profile. Like you said, he has xanthelasma.
Yeah.
You mentioned ECG, which is good. Regular echo. Blood culture, which is can mention that no problem. Renal function test, basically. They want to do drug monitoring. INR in this is very key in this patient. INR, the point that the examiners want to hear you say, INR, you must mention INR in this patient as a follow-up.
Yes. Yeah, because it was I did not get the case. I'm like I did not read this.
I understand. Basically. Yeah. So the things that you have to pick from this scenario is that look at the whole generally, look at the patient holistically, look at the scar, and then look at the back majorly. Some cardiovascular systems, sometimes the pupillary crash, or probably ecchymosis or whatever, rash of the warfarin, it might be at the back.
Yes.
Not really in the front. So as you expose the patient, try and look the back. Or sometimes when you are listening to the chest, the biphasic repetition. Did you check the biphasic repetition?
There was no time. Like Dr. Basim said, finished.
You should have seen it when you look at the back to check. But you didn't mention. That's how I should have told you. But these are some of the things. By and large, you did very well. Then I think let me end it here. Thank you, Aisha.
You're welcome, Dr. Henry. Yes, Dr. Basim.
Yeah, thank you, Dr. Henry. I will comment now.
Yes, sir.
Okay.
The steps of the examination went good. And even you remember the xanthelasma, which is very good. Some of the docs will not notice it, they will not examine it even. But you did so. What I want to say also, what the aim of this meeting while you are doing short station without a patient, usually in the exam, whenever you will pick up the finding, while presenting, you forget. Sometimes you are presenting the small things, sometimes they are presenting the important things. So the examiner will judge you on what you presented. Did you mention the important finding, or you just mention, for example, I noticed this patient is having a scar. Do you think the scar is important? Yes, midsternotomy scar, something fatal. If you didn't mention, they might minus you. Why? Because the diagnosis will be based on your finding of the scar. The harvesting as well, you mentioned the harvesting scar, but you didn't correlate with the patient presentation. You didn't say it one of the differential. What do you think?
Yes, my boss, yes.
So you should mention and you should say the relevant diagnosis related to the finding. Here the finding harvesting scar. So yes, there is valve replacement, but I agree to say also there is CABG possibility, right? So you have to mention the CABG along with the valve replacement. Yeah, what other finding you can say and what you can forget? Here, the flow murmur. What do you think the flow murmur is?
The systolic and diastolic.
Yeah, related to what?
Related to stenosis.
Or to the replaced valve. The blood flow through the replaced valve.
Mechanical valve.
Yeah.
Dr. Basim, I did not get your question. Can
the flow murmur usually happen either with anemia or whenever you have
a hyperdynamic
replaced or mechanical valve and the blood flow through this valve.
Yes.
Okay, some examiner they want you to mention, but it's not that major thing to mention in this scenario. And by the way, even you can miss the finding of flow murmur. It's not that much clear like the pathological murmur. You got my point. So here, what the important to mention and what to miss, the if you want to say the murmur, flow murmur, or the mid sternotomy scar, so you have to mention the mid sternotomy scar rather than mentioning the flow murmur. What I want to say, there is finding you have to mention, and others, if you want to skip, it's okay. But do not skip the important finding as the sternotomy scar, the clubbing, the finding of heart failure, or the finding of infective endocarditis. Collectively, you can mention at the end of your presentation, sir, I couldn't appreciate finding of heart failure, or finding suggestive of pulmonary hypertension, or finding suggestive of infective endocarditis. Okay, or usually say this sentence at the end. And by the way,
Okay.
some examiner, they are hurry to listen to finding quickly because they have 1 minute for the presentation, 1 minute for the differential, 1 minute for the investigation, and the last minute for the management plan. Okay, but I heard a word from you. You mentioned rheumatic fever. Do you think rheumatic fever one of the cause of replacement, indication of valve replacement? Is it rheumatic fever or something else? So all rheumatic fever will be replaced with the valve.
No. Of course, if it is symptomatic,
So what we call it? Is it rheumatic fever or rheumatic heart disease?
rheumatic heart disease.
Yeah, there is a difference between rheumatic
Yeah,
fever.
rheumatic heart
Okay,
disease. Rheumatic
you,
heart
you
disease.
mentioned rheumatic fever, okay?
Yeah.
Take care of
Okay.
the terms you are mentioning.
Yes.
Yeah, the investigation for any patient with follow-up mitral replacement or any valve replacement,
Echo.
please don't forget, not echo is as a bedside and the
Mm.
definite one or the investigation of choice. But I'm talking about the general and specific. Always mention in the general coagulopathy or coagulation profile along with the CBC. What are the importance of CBC here?
Anemia can
What
be
type? Yes, they will ask you what type of anemia could be here.
hemolytic anemia because of the
So
valve.
hemolytic
Can
anemia will be presented with
um,
how it could be presented in the CBC, differential CBC.
the hemolytic anemia, how it will look like.
Yeah.
High haptoglobin, low haptoglobin. LDH
No,
will be
no, in
high.
the CBC.
LDH will be high.
Yes, this is as hemolysis workup. I'm talking about CBC as a differential, how it could be presented.
Low hemoglobin.
Yes, in the differential of CBC. Low hemoglobin, of course. What other finding to just suggest the type of anemia?
Microcytic, normocytic. That MCV will be normocytic.
Exactly. Yes,
Yes.
this is what I want you to say. So it's normocytic,
Normocytic.
normochromic anemia. Yes.
Normocytic. Yes.
Okay. Starting for the CBC, you will see this.
Mm-hmm.
Then the other hemolysis workup as a specific. Okay.
Yes.
And the kidney function, of course, liver function, coagulation profile. And they will ask you, what do you think the coagulation profile will be?
Uh, the PTP, because he's clotting, then
Yes.
INR will be raised.
Perfect. He will ask you what target of INR in the replaced valve, either
2 to 3. Yeah.
mitral
The,
and aortic.
yeah. In mitral, it will be more. In aortic, it can be
Give me numbers. They will ask by this numbers, detected number,
2.5
not
to 3 in mitral, and in 3.5, 2.5 to 3.5 in mitral.
perfect.
Yeah.
Okay. And
And
aortic.
aortic, it can be 2 to 3. It can
Okay.
be
And if you have patient with valve replacement along with AF, mitral along with AF,
it
how
will
much
be
the therapeutic INR supposed to be?
because AF can cause coagulation. Yeah, it can cause clot. So I think not, I think it should be lower.
No, it should be
It
higher.
should
You
be
have
higher. It should be higher.
yes.
It will be clotting more, right?
Yeah. So how much the target?
4?
Yeah, 3 to 4.
3 to 4, right?
So
Okay.
2 to 3 for
Written.
aortic, two to
Okay.
point five to 3.5
AF plus
for mitral,
mm-hmm.
mitral and AF 3 to 4, 3 to 4.
3.5
Okay,
to 4. Okay, sir.
clear.
Yes, sir.
Then yeah, the bedside test you mentioned the ECG, the echo,
Mm-hmm.
and you can mention also pulse oximetry, urine dipstick if there is glomerulitis you suspected, and the chest X-ray. Of course, if you suspected heart failure as a complication, specific also you have to add BMP along with troponin. Right, these are the
Yes.
cardiac enzymes you have to mention. The management, as you said, according to the presentation,
Sure.
fever and loss of weight and night sweats, B symptoms. This patient should be treated as
Endocarditis.
infective endocarditis.
Yes.
Antibiotic techniques, culture,
Yeah.
Duke criteria. They can ask about Duke criteria or the major, the minor,
The minor
the
one.
interpretation, and so on. The heart failure management. If the patient present with short of breath, so you will talk about heart failure, how to manage diuretics, acute state,
Diet.
ABC, and so on. And that on
Yes.
the long term, patient kept on ACE inhibitor and diuretic spironolactone
Mm-hmm.
according to the patient kidney function, right? And
Yes.
potassium level. The other, yeah, and we mentioned the infective arrhythmia. If the patient is present with anemia, so we can give the patient either rhythm control or the rate control according to the duration of the AF.
Mm-hmm.
The last, as a complication, might be there medication complications, coagulopathy, INR high,
Yes. Yes.
yeah, high target INR 5 and to 8, bleeding,
Mm-hmm.
thrombosis. So according to the presentation, you will talk about how to manage each complication. Follow up means this patient suspected to have all these complications since he's having the replaced valve
Already.
along with the cabbage, or which
Yeah.
is coronary replacement or coronary artery disease. Don't
But
forget lipid profile to be controlled by atorvastatin, okay?
yes.
Yes. So this is the case. Thank you, Dr. Henen. It's a very common one. The harvesting scar, by the way, starting,
Yes.
I prefer to start when you said I would like to stand at the end of the bed to ask
Yeah.
the patient to extend the legs and expose them. Sometimes, if you miss the leg scar or a harvesting scar, you might miss the case,
Mm-hmm. Yes. True, sir.
right? You
Yeah.
missed it already today. You mentioned only the replaced.
Mm-hmm.
Take care, you can mention both replacement
Yeah.
along with the
The,
aortic or coronary artery,
mm-hmm.
okay? Or
Okay.
coronary artery grafting.
Yeah. Yeah. Sure.
Okay. Thank you, Dr. Aisha. Any question or comment before moving?
I just feel that I get more. I I know the the things, but I get panicked. I'm still not getting
Okay.
over it.
Try next time to read the instruction. Be sure that you read the instruction.
Yes.
Okay.
Yes.
We
Yes. Yes.
usually read the instruction before entering,
Yeah. Yeah.
but you
Today
have
you.
no
Today.
problem. It's okay. It's okay.
Yeah. Yeah. Yes, sir.
You can post your scenario for Dr. Hinari now to start the second scenario.
Okay.
I will read the comment quickly. Dr. Salma, what exactly diagnosed in this case? So it was replaced, mitral valve replacement and CABG. Which valve is replaced and how I can know? How to know? This is a clinical experience. Whenever you do the clinical examination, you have to know from the click. Is the click in the first heart sound or the second heart sound? Clicky first heart sound means mitral valve replacement. Second clicky heart sound means aortic valve replacement. Dual or double click means mitral and aortic valve replacement. Okay. So it depends on your finding and it depends on your experience on auscultation. You have to auscultate both cases, aortic and mitral and the dual, both double valve replacement. Both of them you have to auscultate, or three of them. Okay. Dr. Henry, your patient is 34 man,
Yeah,
examine.
34 years old examining him.
Perfect. I like to be in the same system. Okay.
Mhm.
Ready,
Yeah.
Dr. Hinel?
What's the name of the patient? John Smith. Is it a man or a
Yeah.
woman?
Yeah.
Okay, man.
He's a
John
man
Smith.
and John
By
Okay.
Smith.
by the
Yeah.
way, it's not necessary to have a name. It's just this is your patient. No need to have good or long conversation with the patient. It's one sentence and instruction. You are here. I will examine you. I am Dr. X. You are 34 years old. No need to mention his name, and
Okay.
give him instruction that if you feel pain, let me know, or discomfort, or my hand are cold. I'm so sorry for that. Then proceed. Okay. No need to say
Okay.
even for Dr. Aisha. She said, I will examine your hand, I will examine your legs.
Mm.
It's
Mm.
I'm here to examine you, because whenever you are reading more instruction or telling to the patient more instruction, you waste at least 10 seconds, which is could be fatal for something you have to examine, like the legs, for example. If you miss the leg examination in 10 seconds, it will take 10 seconds, right? If you miss them, you might miss the case. So no need to talk to the patient, and they will tell you don't talk to the patient long. Start examination, doctor. Okay? Yes, Dr. Henry, here you go.
Okay.
Okay.
Hello, I'm
Hello.
Dr. Henry, one of the doctors. May I confirm you are Mr. John Smith, 34 years old?
Mm-hmm. Yes.
Okay. May I have your consent to examine you?
Yes.
Okay. So I'll step back and look at my patient from head to toe, ensure that my patient is exposed properly. The
Mm-hmm.
legs are exposed, the hands are exposed, the chest are exposed. Then go to the foot of the uh, the during the course of my examination. If you feel any pain, please do it to let me know. Can I please go ahead?
Yeah, sure.
Okay. Okay. I look at the foot of the bed of the foot. Check any vein avesing scar. The
No.
legs. Okay.
No.
Then go forward and see. Look at the appearance. Is he having any malformed epitus? Is it tall? Look at the hands. Then look at the wrist. Check for the hands. Can I see hands, please?
Yes.
Can I see then check for finger clubbing, check for the capillary fill, then look at the hands, check for any last nodules, any general lesions, check for any
No.
scars, any bruises, any signs of warfarin toxicity, check for any scars in the hands, then check the pulse and calculate the pulse, the character of the pulse, the volume of the pulse, check for
Mm-hmm.
any
Um.
thickened arterial wall. What's the pulse like?
Yeah, the pulse is slow rising.
Slow rising pulse.
Yes,
Okay.
and it's a narrow. And
Okay. Yes. Now pulse pressure, right?
yes.
Okay. Good. Then check for the any radial delay.
Hmm? No,
Any
no, no,
radial
no,
delay.
no, no
Okay.
delay, no delay.
Then radiofemoral. Okay. Good. Then look at check for any locomotor brachialis.
No,
Okay. Then
no.
check for what is the blood pressure?
Blood pressure is no, normal. Like,
Normal. Okay.
yeah,
Then do you have any pain on your shoulder?
no.
Okay. Then raise the hands up. Check for
Mm-hmm.
collapsing pulse.
It collapsed.
It's collapsed. There's collapsing pulse.
Mm-hmm.
Is there collapsing pulse?
Yeah, like
Okay.
you don't feel okay. Okay, yes, there is a collapsing pulse.
Okay, it's collapsing pulse. What's the volume again? Sorry if I don't.
I
The
said
volume is
narrow,
it?
narrow.
Na-
It's a narrow
okay.
pulse with small filling,
Oh,
slow
okay.
rising pulse.
Okay, lovely. Then check look at the check for the JVP. Can you please look at the other side? Look at your right for me, your left,
Mm-hmm.
sorry, for me. Then look at the neck, check for any visible position. If you have any pain in your tummy, then press the tummy and see if you have any for hepatojugular reflux, anything. Is it
No,
elevated? Then go to
no.
the the eyes, check for the any pallor, check for
Yes, there
there's
is
pallor.
little. Yeah.
Okay. Then look at the mouth, look at the mouth, check for any cyanosis, check for any dehydration, check for any eye arc palate, no eye arc palate. Then go to the neck, then observe the neck and see any neck swelling, nothing. Then go to
No,
the precordium and check the precordium. One check for the palpate for the apex. Is the apex, is it displaced?
no.
Okay, apex is not displaced. Then look check for the heave, apical heave, left parasternal heave, then checking all the aortic area and the pulmonary, palpate them. Anything, any heave and visible palpation, no. Then
No,
auscultate.
no,
Then
no thrills, no thrills.
no trees. Okay, then use my left finger to put at the carotid. Then check for the heart sound. S1, S2, right?
Yes.
And
S2
any
is
additional
soft.
S2 is soft. Okay. Then check for the any murmur at the apex.
No.
Okay. Then check for the tricuspid. Any murmur in the tricuspid. Check for the aorta. Any murmur at the aorta.
Yes.
Then
where are you checking for aorta?
Both are the right side of the right parasternal area, the second intercostal line, second intercostal space, and then at the EPS point, which are the third intercostal space too. Check while leaning forward, and then in and out. Tell the patient to in and out. I'm timing my murmurs. Anything in and out.
Yeah, there is a murmur in the aortic area.
Okay, what's the character of the murmur? Is it diastolic or systolic murmur? Is it an
It's
ejection systolic murmur? Ejection systolic murmur. Okay,
yes.
check if it's radiating to the axilla. Sorry, to the carotid. Does it radiate to the carotid?
It is not radiating anywhere.
Okay, it's not radiating anywhere. Okay. Then after I'm done with that, then the patient lean forward, check at the back, check for the auscultate the neck for any blew. Then go to the back and then check for the babasal any crepitation, babasal crepitation.
No, almost
at
clear.
the back. Okay, then go to the leg, check for pededema. Any pededema?
1 minute left.
Okay, no pededema. So they find okay, no pededema. Then thank my patient, dress him properly, and then collect my thoughts and wait for my examiners to ask me to fire down. Okay.
Okay, so Dr. Basim, can we start?
Yeah. If you're ready, let's start. Okay.
Okay, so what are your positive findings?
I've examined this 34 years old man who on general examination inspection there is on general examination is not in any obvious respiratory or cardiovascular distress. There is on palpation there is the pulse. He has narrow pulse pressure with slow rising pulse. Slow rising pulse. There's on auscultation or precardial examination, there's soft soft S2 with ejection systolic murmur at the aortic area who does not radiate to the car, and these are my positive findings. Looking at my patient, most likely he has evidence of severe systolic aortic stenosis. Other differential diagnosis may include aortic sclerosis, and also it could also be due to hypertrophic obstructive cardiomyopathy, and other which is the other differential diagnosis in this case could also be pulmonary stenosis, and these are my likely my likely differential diagnosis.
Okay, so you said that you have a differential diagnosis of aortic stenosis and pulmonary stenosis, right?
Aortic stenosis
as well as pulmonary. You said differentials. One of the differences is pulmonary stenosis along with aortic stenosis, right?
Yes.
So how do you differentiate? What other clinical finding you can see in pulmonary stenosis that you cannot find it in aortic stenosis?
Okay, thank you. In pulmonary stenosis, I expect to see there may be palpable P2. There may be palpable P2. There may be palpable P2, and then there may not be narrow pulse pressure, and also there may not be the sound. I expect to hear the ejection systolic murmur more in the pulmonary area than in the aortic area. And then, basically.
Not in auscultation, but what can you find in when you palpate?
I'm also palpate the left, right, what do you call it? Left parasternal heave.
Yes.
And then,
So what is parasternal heave? What is it?
That may be due to tricuspid
Right ventricular hypertrophy, right?
Yeah, right. Sorry, right ventricular hypertrophy. Sorry.
Okay. Okay. So now aortic stenosis. What can be the etiology for aortic stenosis?
Pardon? Radiology?
Etiology. What can be the reason for?
Going by the age, it could be due to the congenital bicuspid aortic valve. Also, other conditions may be due to rheumatic heart disease. And then, if it's an advanced patient, or it may be due to calcification of the aortic valve. Basically, these are the likely cause of the degenerative cause. Yeah.
Okay. So when you said it is severe, how do you know it is severe?
Because of the narrow pulse pressure that he had and the soft S2. Basically, these two signs are features of severity of aortic stenosis. He has he has a slow rising pulse and a narrow pulse pressure. At the same time, he also have a soft S2. These are some of the features of severity of aortic stenosis.
Okay, we can give it to you, but you did not find any signs of heart failure.
No. The heart failure may not be there. Heart failure is one of the severity of aortic stenosis, but it is not present in my patients.
Okay. How will you manage the patient? What will be the criteria of surgical replacement?
Okay, first of all, I want to investigate the patient to check the bedside cardiovascular observation, look at my bedside ECG monitoring, echocardiography to know the severity, to assess the severity of the heart valve and see if there's indication for replacement. And basically, which may include the aortic valvular area of greater than aortic valvular area greater than less than 0.6, some say less than 1, depending. Then also the velocity may be greater than 4 meters per second, and also the gradient greater than 40 meter mercury. So these are the echo findings of severity. And any of them, if there's underlying heart failure or there's any other valvular problem, these are other features, the indication for aortic valvular replacement. It can be either through the TAVI or through surgery or through the
surgery. Yeah. So who can go for TAVI? Like who will go for TAVI and who will go for the surgery?
Thank you. For TAVI. TAVI is usually recommended for young patients and those that doesn't have any underlying comorbidity. That young patient that does not have any other comorbidity that's any other valvular comorbidity, and also and patient that we have contraindication for surgery basically.
So young patients will go for TAVI?
Young patients typically are more, young patients that have no comorbidity.
He's 34 years old. What you will do for him?
This case,
you will do the surgery or you will replace the valve?
If there's no underlying comorbidity, I'll go for TAVI.
Okay. Generally, we replace the valve. So yeah, you did very good. You're finished, Dr. Basim?
Yeah.
Yes, it's enough. He mentioned the management, right?
Yes.
Okay, you can talk now about the performance.
Yeah, you did very good, Dr. Henry. And you did very good. Everything was correct, and it was a straightforward AS case. And only thing is the management. I think when you're talking about the management, you can go through it. The replacement of the valve and the surgery. Dr. Basim, maybe Dr. Basim can tell more, because we replaced the valve in the olden.
Yes, I agree.
Surgery,
yes. In young patient, it's surgical.
The surgery,
the TAVI for the elderly one.
The TAVI is for elderly because they cannot undergo the surgery, and
exactly.
The coagulation is also.
I want to ask him one more question. If you have suspicious of aortic stenosis, what investigation you should do before deciding for surgery?
Yes.
Thank you very much. Part of the investigation I want to do is to do angio in my patients. First of all do angio before the surgery to rule out evidence of MI.
Yeah, yes, it's one of the impressing tools you have to mention to the examiner. They will like this sentence. I would like to do CT coronary or coronary angiography if there is any evidence of coronary artery disease. So the patient might go for CABG along with the valve replacement. Okay, continue, Dr. Aisha.
Best, Dr. Basim. I think that was the
This
only
is the
thing that
only.
I thought.
Okay.
Yeah.
Okay. The case is aortic stenosis or
Stenosis.
sclerosis.
Yeah,
Stenosis.
it's stenosis. Yes, sir.
Okay, but the stenosis, suppose the carotid will be there is a thrill, right?
Yeah, yeah, but it depends on the severity as well. If the murmur is like not that severe as well, then the thrill
Okay,
won't hurt
yeah,
anyway.
yeah, you're right. But
Yeah.
supposed to be the difference between aortic stenosis and aortic sclerosis, the radiation to the carotid. You get my
Yes.
point.
Yes,
Yeah,
yes, yes, sir. Yes, sir.
yeah.
Yes, sir.
Mm.
And
Yes,
again, this point also examiner they like to hear it.
yes.
Whenever you mention the pulse, sorry, the murmur radiate to the carotid,
Radiating. Yeah.
so you can conclude this is aortic stenosis. If not radiated and you have ejection systolic murmur in the first aortic area, I I agree to say this is aortic sclerosis. And they are asking the difference between both of them. What the difference between the aortic stenosis and aortic sclerosis. So you can mention this is
Mm-hmm.
as a major difference. Okay.
The radiation of the
The
murmur, right?
radiation. Exactly. Yes.
Yes.
Yeah. So in general, yeah, Dr. Henry did well
Okay.
the steps, but I like to or I prefer to start examining the legs before examining the heart and the other body, even the harvesting. So I would like to do step back, okay,
Mm-hmm.
examining for the chest and the scars and the patient sitting. At the same time, while I'm beside next to his legs, I will
Mm-hmm.
examine his legs. This is what I used to do and I used to advise. Whenever you are down at the end of the bed, examine the legs. Then move forward to the hand, then the neck, face, and chest examination, heart at the back for bibasic crackles, sacral edema. Thank the patient and go to the examiner. This is my favorite step or approach to do the cardiac examination. Okay.
Yes.
Yeah. I think we covered most of the points in the previous case.
Yes. Yeah.
Yeah.
And yeah, I think the only thing is like that vitamin we can use for the exact precise size of is the heart not bumping. But
Yeah.
that's too much. That's too much of theory. I think no need for that as
Yeah,
well.
more details, but sometimes
Eh,
they are asking for it. But echo, you have to mention the golden standard for investigation, aortic
mhm.
stenosis, and don't forget to say the indication of replacement. You didn't ask this question.
Uh,
What are the indication for replacement, Dr. Henry?
For aortic stenosis, is it aortic stenosis or is it
yes,
for aortic stenosis?
Yes, yes,
yes,
aortic
yes.
stenosis. What the indication of
Okay.
surgery
Yeah,
or
yeah.
replacement?
Indication for replacement. You get severe symptomatic aortic
Perfect.
stenosis.
The first
Yeah.
sentence to mention symptomatic,
Mm.
severe symptomatic aortic stenosis. Okay, second.
And second is asymptomatic severe
Okay,
Echo.
yeah with and also it could also be due to asymptomatic aortic stenosis with other cardiac
how to?
abnormality.
Yes, how to know?
Yeah.
Tell me this. You
Echo.
said symptomatic, asymptomatic.
Yes.
Asymptomatic with
Yes.
other manifestation. What could be the other
Yes.
manifestation?
If there's maybe any valvular abnormality alongside the aortic stenosis, like it could be maybe evidence of CABG you want to do
Okay,
alongside maybe a myocardial infarction, or also it could be due to any other congenital abnormality.
okay, another disease. Okay,
Disease,
I
yes,
would I would
basically.
like to add one more question for the symptomatic. What symptoms of aortic stenosis you know?
Okay, the symptoms may include this shortness of breath, syncope,
Perfect,
and
perfect.
Yes.
angina.
Angina.
basically.
Perfect. Okay, so heart failure or angina or syncope, any of
Yeah.
them, yeah, you have to do the replacement. Let's go to what other
Pacemaker.
finding you can judge on them, guide you to the replacement apart from the symptoms.
Other findings could be due to echo evidence of
Perfect. This is
severity.
what I want you to
Yeah.
say. Tell me the
Yeah.
echo finding indicate aortic replacement.
The echo findings may be they may have
You already
soft.
told.
I mentioned them. Soft
Yeah.
S2. They may have
No,
narrow pulse
size.
pressure. They may have
Echo.
Echo,
okay
you
echo
are,
echo
you are yeah, echo
okay echo
finding.
okay echo finding. Sorry, echo finding. The aortic valvular area may be less than
Yeah.
Perfect.
1,
For
and then
any
the
stenosis,
yes.
okay, 1 second only. Phase. For any stenosis, you can mention the surface area of the valve. It's an indication for replacement. What else?
Then the velocity.
Perfect.
Ejection
The
fraction.
velocity, the same as mitral stenosis. Any stenotic valve, you can say the velocity. I can judge on that for the replacement. The last is
The gradient, pressure gradient.
gradient. Exactly. So any stenosis, I can say as echo finding, the velocity, gradient, surface area, I can use them as an indication for replacement. Apart from that, apart from the echo finding, what can you do? Another test to say this is,
Apart from
yeah,
stress test, you can do a stress test.
perfect. Yeah. So any what the common indication in the stress test to say this is an indication for aortic replacement?
Common indication for stress
Whatever you
test.
do, yeah, the do stress or the exercise.
Yep.
Suppose the heart rate will be increased, the blood pressure will be increased. Instead, in aortic stenosis, the opposite will happen.
Yes. Yes.
So the
Okay.
Yeah.
reflex tachycardia or the hypertension,
Yeah.
suppose it will be the opposite. So this is
Okay.
an indication for replacement. Okay, so any
Mhm.
the case of heart rate or hypotension with this exercise, you are indicating or you have indication for replacement. Okay.
Okay.
Okay, what are the pharmacological options for aortic stenosis?
For aortic stenosis, pharmacological options may include the beta blockers, basically.
Perfect. This is the
Um,
gold standard. What else?
mm, to after beta blocker, I think other 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 drugs may use
And
after beta
give me
blocker.
drugs you to use and drugs to avoid.
The drugs to avoid typically are the nitrates and the
Afterload
Perfect.
reduction.
inotropes. The
Yeah,
inotropes.
inotropes and
Nitrate and yeah,
vasodilator
yeah,
or
vasodilators and then the
diuretics or diuretics
diuretics. Yeah,
Yes.
yeah.
or inotropes.
Mm.
And to use beta blocker. If you have
Yeah.
heart failure, how you manage?
If there's heart failure, that is with aortic stenosis is an indication for one, is an indication for surgery, for
Yes, sure,
replacement.
sure. But what other
But
pharmacological
for
options?
pharmacological option may include the we want to start the beta blocker, like I said earlier on, the um, S inhibitor may be included too. In this case, also we want to. These are the two major drugs. If there's any, if the other drugs may be added, I think
For any heart
these are the
failure, what you have to do?
for heart failure. In heart failure, basically you give a diuretics,
Exactly. Yes.
depending
This.
depending if they're having heart failure with reduced ejection fraction, for instance, want to
So
start
lobe
them with
diuretics. Yeah, lobe's
loop
diuretic.
diuretics.
Yeah.
Yes.
Okay.
Mm.
You will use lobe diuretic or even sometimes vasodilator if you have heart failure. Otherwise, it will be contraindicated. For beta blocker, whenever patient on beta blocker and he has heart failure, this is according to
Acute.
guidelines. Yes, updated. What you want to say, Aisha, Dr. Aisha?
Acutely, we will try to avoid acute heart failures. Beta blockers, we will be avoiding.
No, it's not. If he is on beta blocker
If
earlier,
Mm.
he is, we
so
will
you'll
continue
continue.
it. We will
Exactly.
continue
Yeah,
it.
you
Yeah, we
continue.
will
Yeah.
not
But
stop
don't
it.
start or don't commence a
Mm.
beta blocker if
But
the patient in failure. Okay, it's
yeah,
contraindication.
so,
Only
so
continue if he has already on the medication. Yes, Dr. Aisha, what you
yeah,
want to ask?
I want to say that Dr. Henry just said for aortic stenosis,
Mhm.
ACE inhibitor, we will not give ACE because already he is like having problem with afterload. There is no blood going forward anyways. And if we
Yeah.
give any drug that reduces the afterload, like ACE inhibitor, it will further be problematic because,
Yes. So
yeah,
yes. So whenever you are having heart failure, ACE also you can use, but in the asymptomatic aortic stenosis.
aortic stenosis, yeah, we will try to use it very cautiously or we'll try to avoid it
Yes,
because
exactly. Yes,
we will,
any
we don't,
vasodilator or any
yeah,
diuretics, it's contraindicated.
yeah,
Okay, so
yeah.
we spoke about the aortic stenosis in details. The
Mm,
last thing we'll talk about the differential. What are the differential? And Dr. Henry already mentioned them. I will repeat them for the teaching point. Aortic
mm,
stenosis, aortic sclerosis, and the difference we mentioned, pulmonary
mhm,
stenosis, and HOCM. All of them are systolic or ejection systolic murmur you have to mention
mhm,
whenever you are saying the differential of aortic or ejection systolic murmur. The also important point whenever you have young patient, usually they have aortic stenosis. However, the elderly one, usually they are having aortic sclerosis. This is also a major difference between the sclerosis and stenosis. By the way, the most clear murmur you will ever hear in all pathological valve disease, the aortic stenosis.
stenosis,
It's
yeah.
yeah, it's very nice murmur. You will hear
Mhm,
it all over the pericardium. It will
yeah,
not be radiated to the apex and radiated up to the
yeah,
carotids. Along
okay.
with that, you will feel the pulse, as Dr. Aisha mentioned, slow rising pulse, no collapsing pulse at all.
Yes, it
Whenever you have collapsing pulse,
it's very good.
yeah, so you can say this is double valve lesion, aortic stenosis along with aortic regurg.
Yes,
Okay, the
yes,
complication of aortic stenosis, as we mentioned, and for any heart or valvular heart disease, heart failure, arrhythmia, or infective endocarditis. So always mention the infective endocarditis as complication. Okay,
mm,
any abnormal valve or any valve lesion could be complicated aortic infective endocarditis, particularly the replaced one.
mm,
And you can add one more sentence in bracket with past history of infective endocarditis. Any patient with infective endocarditis, previous history, he will be
mhm,
having more suspicious to have infective endocarditis again. And it's one of the major criteria. No, it's not the major criteria for rheumatic heart disease, but not for rheumatic infective endocarditis. Infective endocarditis, so I think it's one of the minor, sorry. One of the minor criteria, if the patient is having previous infective endocarditis, you can add it to the minor criteria. Okay. So
mhm.
the major criteria will be depend on the echo finding and the blood culture.
Blood culture.
The minor criteria will be DUC criteria I'm talking about. Minor criteria, previous infective endocarditis, one of them, fever,
Mhm,
and immunological and vascular phenomena.
yes,
Immunological as Roth spot and the oslar
in-
nodule.
mm,
The vascular, like
mm, uh,
the
yeah,
splinter hemorrhage, right?
mhm,
Splinter hemorrhage.
yes, and
And we forget also the immunological
in the eye, there is also one
What
and the eye
spot?
Roth spot as
rod spot and one more hemorrhage is also there,
immunological.
right?
Roth spot is immunological one, right?
Yes, yes,
Mm,
Yeah.
rod
And
spot,
the kidney, the
yeah,
hematuria or the glomerulitis.
glomerulitis.
Yeah, this
glomerular.
is also one of the immunological. Okay. Any
Yes.
question for both topic? Nice session about cardiovascular. We revise a lot of topics and points, questions, differential investigation, and the management plan. Don't forget the infective endocarditis to mention either on the presentation. I couldn't find findings suggestive of infective endocarditis. And whenever you have suspicious of infective endocarditis, I would like to add investigation for infective endocarditis. Okay.
Mhm,
Any doctor who's doing exam for PACES, he should and he must read about infective endocarditis. No exam will pass about cardiac station without touching the point of infective indication, the criteria, the management, the how to investigate, how to diagnose. Okay,
Mm.
it's
Sir,
very important. Yeah,
sir, as you said that during our exam, like when we present our case, if we don't find the signs of endocarditis, we still have to mention it that we did not find anything, or
heart
if we
failure,
let it.
pulmonary
No, no,
hypertension. Yeah,
no. The signs of infective endocarditis. If we did
yes,
not find any splinter hemorrhages or slow
yes,
nodules, so
yeah.
do we have to mention it, or if we let it slip down, is it okay? Or we do have to say that we did not find it?
Yes, you have to say it at the end of your presentations. Don't start to mention them if negative.
Okay.
Mention them at the end of your presentation. Sir, I couldn't find signs of infective
Mm,
endocarditis, heart failure, pulmonary hypertension. At the
okay.
end of your presentation, don't start to mention them at the beginning. They
Okay.
dislike this. Okay, they don't like to start. I couldn't find. So what you are presenting, the one you couldn't find or the one you find.
Okay.
Okay. Yeah, this is
Yes. Yes, sir. Yes, sir. Makes
okay.
sense. Makes sense.
Thank you, Dr. Aisha.
Thank you, Dr. Qasim.
Dr. Ala. A's and RB's should to be used with cautious. Of course, there
Yes.
is cautious, but it's by default, it's not the major treatment for aortic stenosis. Dr. Ala, also, sorry, what was the first case about? Was about mitral replacement or replaced mitral valve along with cabbage. So I will
Mm,
share the photos. Please follow the Facebook group. I am sharing the discussion, the photos, the picture for aim, any discussion have done in the session. You will find in the post in the Facebook group because I couldn't find a way to share them in the YouTube channel and in the WhatsApp group. It's not easy like in the Facebook group. Okay. Anyone has a question before ending the session?
sir, uh,
Yes, it's Aisha.
I
Yes.
know. Sir, we have 10 minutes for communication, right?
Yes.
In 6 minutes, I will be doing my examination and everything. And in 4 minutes, I will be with the examiner, is it?
Yes. Yes. Exactly.
And I
No, no,
can
no.
take
Wait. You mean you are talking about communication?
no.
Communi
I mean the short
short.
clinical, yeah.
Yeah. 6 and 4. Yes. Oh, yes.
So
What?
so 6 minutes I will be doing the examination,
Yes.
and then
Yes.
4 minutes I will be with the
Yes.
examiner.
Exactly.
And they ask the standard questions, or they can ask anything, sir. Like we always, when we do our cases here,
Okay. I
we
was.
only. Yes, sir.
That's why I'm focusing on the part of the skill wise. You are
Mm,
asking about what the presentation, what's your case
mm,
about, the finding.
mm,
Why
mhm,
he's asking about the finding? Because there is two skills about the finding, physical examination
mhm,
and identify the finding. Okay?
mhm,
Two skills on this question. Present your case. And
mhm.
he will also notice how you are examining the patient. This is another skill. So two skill. One for the physical examination, he will observe, then identify the finding either by showing the examiner doing the examination or while you are presenting. So these are
Okay.
two skills, and every skill 4 marks. And as you know, the short
Mm,
are 20 marks. So you have 5 skills to be judged on. We finished
mhm,
two of them. Okay, physical
mm,
examination, identify the finding. The
mm,
third skill will be on the judgment, clinical judgment. So he will
mm.
ask you what to the investigation, the management plan, and so on.
Okay.
And one more for the differential diagnosis.
Mhm.
As you know, we are discussing in each scenario the differential
Yes.
diagnosis for this reason because it has 4 marks as well. The last skill, which is easy to gain the marks for them, the welfare. You are respecting the patient, you are not harm or
Mhm,
doing or you are not hurting the patient. You didn't hurt the patient by any way, by
mhm,
a cold hand or even by doing bad to the patient, bad behavior, or
mhm,
patient fall down in other station. All of
mm,
them are in the skill of welfare. Now you have 5 skills, everyone with 4 marks, in total 20 marks.
mm,
You can gain, as I said, the welfare will be already in your bucket if you do the steps gently And the other 4 marks we are doing in our station, in our session every day. We are talking about the presentation.
Yes,
We are
sir.
talking about the finding. We are talking about investigation,
Differential.
differential, and management plan.
Yes.
So
Okay.
only what you have to train the picking the finding, how to pick
Sure.
up the finding. This is by the training in your practice. But the physical examination, we are saying the steps. Supposed to do them whenever you are going to the exam. But the finding to be picked up, this is depend on your practice in your life. Okay.
Mm-hmm.
Any other question, Dr. Aisha?
I'm only lagging behind in presentation. I always feel that even if I know, I am not able to present it in the right way. That's and it's going to be a problem, right, sir?
No,
If
no, no,
if
no.
I if I cannot present it properly, will it affect my um
Why it
my
will affect? I will tell you why it will affect. Because it will show the impression of you are doing professional or you just do it randomly and you are not organized. You are hesitant. Okay, they will feel that from your presentation. So the first 1 minute can give the examiner either the impression that this candidate has experience or he's not expert enough to have this exam. I'm not talking about previous experience in exam, experience in the life. Are you dealing with the patient in daily basis, or you just came to the exam to have the exam and to pass? If you feel that you are not expert enough, they can fail you from the first minute, which is the presentation. But if they
Mhm.
feel that you are perfect in the presentation, so the other
Mhm.
discussion might go perfect.
Okay.
Okay. Any other
Okay.
question?
That's it.
Okay, Dr. Aisha. Anyone
All
has
right.
a question? Dr. Hinari
Thank you,
or
Dr. Hassan.
anyone? Thank you, Dr. Aisha. Anyone with a question before ending the session? Okay, thank you, Dr. Salma. Seems satisfied all of you. Thank you for the attendance today. Thank you, Dr. Hinari, Dr. Aisha.
Thank you,
See you
Thank you, sir.
tomorrow, inshallah, with the long clinical station day.
Okay.
Good luck and good night. Assalamu alaikum.
All right. Wa alaikum assalam, sir.